Well, thanks everybody. We are the session that's still on the Zoom, as I said, so want to make sure we have a good discussion today. This is part of session 4. We're charged with sort of the overall topic, looking at how our Alzheimer's disease research centers can support historically minoritized communities in a few different domains. The different coordinators, different facilitators, we had some probe sorts of questions, and I just sort of started them on the board. We don't have to do them in any particular order, but just to kind of cover this topic, and I'll sort of copy Dr. Gleason a little bit. You know, I'm a cisgender white woman from rural Ohio is where I grew up, so I'm not the expert here. I'm just the conduit, the facilitator, helping us have some of these discussions, so I hope we can have some good discussions here today. But kind of within that, how can ADRCs, I'll just use that as the short for the rest of this. How can we support historically minoritized communities? There'll be other topics. I think they're probably in your program that will, other sessions will be covering. But when we were sort of brainstorming in advance what we thought that this question might mean, we thought about this in kind of 4 different domains. So first, we've talked a lot over the last day and a half about trust. So what are the key elements that we as Alzheimer's disease research centers can establish trust and trustworthiness with, and it could be whatever community you're working with or that you have a particular interest in. What can that, and then what are the health concerns of those communities, specifically health concerns, and whether you think, like, whether the community thinks that those might be different than the researchers do. That's maybe a side question. And then what are the research questions that we think that are, you know, different minoritized groups might be interested in? And then are there additional things that aren't necessarily related to healthcare, related to research? What are the other things that we maybe think of that community members might value from Alzheimer's disease research centers? So we sort of brainstormed them in that order, but we sort of, I'll start that we maybe should start on the idea of trust and trustworthiness. But certainly this is open up, and I don't know whether, I think we've got a few mics here that we can pass around even. There's a little lever here on the bottom if you want to flip that up if you want to say something, just so I think it gets recorded on Zoom a little better. I'll give one to David here, who's one of our research associates working with our Health Disparities and Equity Corps. You don't have to say something, but you're kind of right in the center to spread another one around. So maybe to start on that idea of trust, how do we, and again, this could be whatever group that you're working with or with whom you identify, that our ADRCs can help to build trust and trustworthiness in the community. What do we think are maybe the key elements? And as I said, I'm just kind of a facilitator, a scribe, a vessel here. Anyone feeling bold? Please pass a mic down over there. Oops, and there's a little, like, if you just push up that little lever in the bottom.
Check, check.
There we go. Perfect.
So I think one of the things that I've experienced is really being intentional on not assuming. And I've observed where some colleagues have assumptions about the community, and they misread the community member, and now they have a perceived conception of how they're going to engage with them. I just had a scenario last week, and literally had to oversee the whole visit to ensure that it was a pleasure. So I was literally putting out fires the whole visit to ensure that it was a pleasurable experience for the community member, because we already know that particularly in the African American community, and this very well may be true for other underrepresented communities, you have that bad experience, and as much of a foundation that you have built, it can be knocked down very quick by that one negative experience because it travels fast. And then there was one other thing, I don't know where this falls in. I think it's really important to understand the culture of the community that you are engaging with. Because, I'm gonna use an example. There was a participant who said she has a drink. You know, she has a glass of wine, or it could have been a shot, I don't know. But she had a drink, and it was, you know, like once or twice a week. And when the study partner was interviewed, it was presented to them as if their loved one had a drinking problem. And that did not sit well with the study partner. So I think, you know, we have to, and I think that falls under trust as well, or understanding, or how is the research question designed that if a person answers one way, does it lead them to another, which may not validate that this person has a, you know, an alcoholism problem. And I think that can be quite problematic.
Yeah, I'm trying to think. I hear what you're saying. I'm trying to think about another way to phrase it. Maybe like, don't put words in people's mouths, or think carefully about how you rephrase what people are saying.
Maybe rephrasing or asking clarifying questions. Because we all know that if we don't truly understand it, then now we have classified someone incorrectly.
Great, thank you so much. And I also want to apologize if you got the worst penmanship facilitator here. So that's just, I'm not going to make it prettier during this whole half hour. So.
We have a request from some of our guests online. It would be great if everybody could please introduce yourselves as you share your thoughts.
Oh, and I didn't even do that, so I will greatly apologize. I'm Krista Moulder. I'm the executive director here at the Knight Alzheimer Disease Research Center, so I will also welcome everyone here to St. Louis. Thank you so much for your time and your expertise. So that's who I am. I help Dr. Morris with the R13 grant, but I am not a person who's well-versed in community outreach. That's not my area of expertise, so I am just a conduit here. Anyone else want to speak a little bit about trust? I see Sarah.
But I figured.
Yeah, it's better to have Mike because we're from the Zoom folks.
Yep. So Sarah Stout, I work here at WashU. I manage the Cognitive Technology Research Lab with Jason Hassenstab. And I had a conversation last night, actually, that relates to this a lot. I think probably the biggest thing that I'm thinking of right now is kind of coming down from our ivory tower, because the university, for some people, is held in really high regard, but others, it is kind of this untouchable place that people don't necessarily want to have anything to do with. And some of the language that we use, I think, can be off-putting to people. And so I think kind of learning to use some of the language of the community, I think, is really important. I went to see a friend of mine last night, and she was busy with some kid stuff, so I was talking with her husband, who is a black man, about 40 years old, and he was asking what I was doing today, and I told him about, you know, this conference for recruitment of minoritized people, and he's like, minoritized? He's like, I don't like that. And sort of what Dr. O'Brien said, that it is not necessarily a community term. And so how do we kind of gain people's trust if we're using language that they don't use?
Great, thank you. I agree with that. When you said ivory tower, I didn't know whether you meant the physical ivory tower that we need to leave, or
I guess both, but I was more thinking of just kind of the idea of the ivory tower.
Any other thoughts on trust before we maybe?
There was a comment online from Joyce Nicholas, and she said that similarly to Sarah, her thought is for all of these items is that we should ask the community. As researchers, we have spent too much time acting in what we think the needs are instead of asking the community what we want to reach.
And I think that's wonderful. I think we'll move that when we get down to the research area. The woman in the lovely green sweater, I don't know if pass the mic to her. Yeah. We believe you. We just want the folks online to be able to hear us.
Yes. So my name is LaQuetta Allen. I'm the manager of clinical research at the University of Alabama at Birmingham, Community Outreach and Engagement. And I agree with all of those bullet points, particularly intentionality, understanding the culture. I try to do, and my partner try to do research on the particular group of people that we're going to be speaking with or, you know, doing outreach events with prior to going to these events. And then just avoid, like you said, some of the, what we call higher verbiage that people don't necessarily understand in some of these communities. But also, one of my big things as it relates to trust is to do what you say you're going to do. If you tell a patient or particular or potential participant that I'm going to call you this week to get more information and to enroll you in a trial, do it that week. Don't put it off. And also, you know, we had an incident where for an entire week we had probably about 6 people scheduled to come in for appointments, and because the person that was coordinating those appointments was out ill, we had to cancel all of those appointments and then reschedule. Well, that paints a negative picture for participants. It's like it sometimes gives the impression that we don't really care. Oh, they were just here, just talking. They don't really care. They may, and then they spread. It's that spreading the word. Oh, I wouldn't enroll in that because they made me an appointment and they canceled it. So do what you say you're going to do. So we're in the process of, or we've already changed our protocol, that if that coordinator is not there, then we have other people in place that we've placed in their position to ensure that we do not cancel appointments on any patients. So just building that trust with doing what you say you're going to do.
Good morning, everyone. I'm Dottie McDowell, and I work here at the Knight ADRC. And one of the things that I think is critical to building trust is to continue to show up in the community. So it's not just a one and done, but it's a give and take. So going to things that are important to the community and not just having it one-sided, that we're coming because we need this for the community, but also to support. And that's how you build trust over time.
Great. I think there was one more comment over here, and then we'll maybe move on to one of the other subtopics there.
Okay.
Please, thank you.
Do you want names and all that?
That was the request from online, so
okay.
Please.
So this is Joshua Chodash. I'm at NYU Langone, and I lead our ORCOR at our ADRC. I think trust is just so essential because it's not only about the trust itself, but it's about what teaches us how to be better if we sort of hold that front and foremost. So what do I mean by that? I think a lot of this is really about listening and asking questions and not having assumptions. And we all have language, and language that sometimes just feels like it's a part of us. But being self-aware, having emotional intelligence, and even asking about that language. How should I refer to you? Do you want me to call you, Mr.? Do you want me to call you by your first name? Not making assumptions, because I'm probably going to be wrong. And I think with all of that, what am I expressing? I'm expressing a level of humility, and I think that humility engenders an increased level of trust. And I really appreciate the comment about showing up, and we heard earlier about having a sustainability plan before you recruit. that's really about making sure that if you go into a community, that you can stay in that community, that if you're going to deliver a service, which I think we are mandated to do, that you're going to be able to continue to deliver that service, that it's not a one and done. And we hear this all the time from our community partners. Oh yeah, you guys were here a couple of years ago, then we didn't never see you. And really the subtext there is like, what do you want now, right?
Yeah. Absolutely. Why don't we segue from there into, because Joyce Nicholas's question from online sort of touched on this a little bit too. From the trust, what research do you think that communities want to be, topics that you think are important to whatever communities you're working with or with whom you identify? What are the questions that you think are important, whether they are or are not being addressed by our current efforts? Yeah, specific to ADRD research, but in with which whatever community, doesn't have to be particular to any one particular group of individuals. So for example, do you think that, that we might be out there and we might be, all about that we want to prevent Alzheimer's disease, and that's what our ADRC is going out there and saying, and we talk to the community, they say, no, I want to know about more caregiving resources, or I want to know about things I can do that aren't necessarily, fancy scans or anything like that. I want to know lifestyle preventions to, that I can work with my group. So I just kind of think like, when you hear that someone's doing Alzheimer research, what do you think the community wants to hear? I don't know if Jen's going to be able to say it better than I am.
No, I just absolutely, when I'm out and about, I think the number one thing I hear about is what is my risk? What does that look like for me and my family? And there's a lot of misconceptions. So even a lot of times it's, let's start from square one and educate about, what are we dealing with? What are myths? What are realities? And then people do really want to know about, is this something that's going to happen to me?
My name is Melita Terry. I'm from the University of Pittsburgh Alzheimer's Disease Research Center, and I'm the Senior Community Engagement Coordinator. I am the visionary, the strategist, the implementer, and the boots on the ground for our center. And I would just like to say that I think the most important thing is asking the community what they would like to have and not go with a preconceived notion of what we feel that the community needs. We're better served by listening. And I think the most important question, if I could sum it up, is being, we need to have the ability to shift. We need to be able to pivot on a dime's notice to make sure that we are providing a service to the community. I found that to be very effective. And even myself, if I have a plan of how I may want to do something, if a community member tells me they want something different, I'm about getting it what they want and figuring out how it can be done. So I think for me, what's very effective is being flexible. You have to be able to shift. You have to be able to pivot. I think that's it. That's all right now.
Lynn Iannone from Yale University Outreach and Engagement Corps. I think one of the things that I've been trying to do is when I go into different senior centers and some of the housing projects, and I talk to the management and ask them and their members, what would you like a talk on? Is it the importance of sleep? Do you need diet and nutrition? And I ask them first what it is, and then I have to search around to try to find someone to give that talk. But I ask what they want, and then, then I have to go out and try to work my hardest to find someone who can offer it.
What do you think?
We did have a comment online a little bit ago from Stephanie Cristofante, who stated that we need to be mindful of the source of information and be flexible with our communication styles so that the community feels comfortable participating in research. She also states that she agrees with everyone else here that we should have less assumptions about what the community wants or needs.
Thank you. Please.
I would just add, I think we need to be we need to build up a breadth of resources, because the last thing I want to do, and I don't really, I mean, I really appreciate your comment about what do you want to hear about, but I think I would take it even one level lower or higher, depending on your perspective, which is, what do you need? What do you think that we might have that you need? Because sometimes what people need is they're not even asking necessarily for information, they're asking for help. And so I want to know that I've got places that I can facilitate to not just make them aware, well, there's this place down, a mile away that you can go to, and here's the phone number. I want to be ready to say, would you like me to help facilitate connecting you to this group that I think might be really helpful? I think that becomes really important. And when we talk about, I do a lot of work in early detection. We have a public health center, and so it's really about health and health care. But they're so analogous. I know it's a Venn diagram, and there's an overlap, and there's some on either side, but there's this piece in the middle that's so analogous to this, and that's really about being ready to listen and deliver. And even if you can't deliver exactly what people are asking for, that you're making an effort to try to make whatever that need is, whatever that gap is, better. And I have to say, I know I'll be a broken record here, it goes back to trust. It really does. Because it's really about being personal, being engaged, being present, and being helpful.
I think those are all good principles. Are there any other we're looking at some broad brushstrokes here about how different resources. I put some of these under the additional category because they're not really research questions, they're not really health concerns, they're additional ways that we can be prepared to respond to things that the community is asking for. I see a hand way back far in the back. You'd have to come down and grab a mic. Anyone else have a question closer up? No, oh, he's running fast.
Sorry, I'm not a recruiter. I'm just an instructor doing research on brain imaging. But most of the points they are mentioning about the trust. How to gain a trust? What is the key element to gain a trust? Because when I'm recruiting participants, like young participants, they have a different criteria because their health is more like conscious, they've never been to hospitalized, or they don't have any health issues, and they have a different criteria to gain trust from them. And people with already having problems, they have a different, we have to approach differently. Different race has to approach differently. So I'm just saying that, how do you gain trust? What are the key elements to gain trust of different genders or different race or different age groups? Are we formulating any kind of questionnaires for that? Is there any resources there? Sorry.
So I think it's getting a little bit deeper. We talked a little bit about trust, and it seems like there were a lot of factors that people threw out there that actually do contribute to trust. So I guess perhaps a version of that question is, are there different elements of trust that are important to different subgroups of people? You gave men versus women, or different groups. I don't know if anyone wants to think about that a bit more.
Hi, online community. It's Dottie McDowell again. So this isn't really specific to the trust, but going back to the topics of interest to the community, I think that it would be great if we could offer some conversation starters, because I think oftentimes families, and I'm speaking from my own personal experience, don't even know where to begin and what the signs are and how they may be related. So for example, by working here, I now understand all the linkages, or more of the linkages, that my father experienced with frequent urination and not being able to sleep, and how all of those things were connected. So I think if we could have some prompts and conversation starters that might help the community to open up to expressing what they need.
No, that's really great. We're bridging all of the categories here too. So I think that when I think for a lot of our conversations that we've had, and people have talked about going and giving first and not asking first. I think some of those, the health concern sorts of areas are certainly, and as Jen mentioned too, people are asking questions about risk and that sort of thing too. Are there other areas that you're hearing when you go out into the community that people are, whether it's risk or conversation starters, how do I talk to my dad about taking the keys away, or those kind of things? Are there other things that you're hearing when you're going out in the community that are important?
Really quickly, I've been astounded by how many, when we've done some fairs, we've gone to some of the local churches, for example, in New York. I've been astounded at how many individuals are not just coming because they want to talk to you about a loved one, they're coming to talk to you about themselves. And so I had the unique role of, and we need to do this more, it's about that being present piece. But as a physician, which I am, sitting there and doing memory screenings, but it really was more than that. It was really, I'm not sure I'm a big proponent of just giving a cognitive test. It was really about conversations and talking to people about their worries and concerns. I think that, that was something that really took me by surprise, because I often find clinically more in the office that this is not necessarily something that people want to talk about all the time, but out there, very much so.
I think that's an important point, thinking that we have multiple audiences. There are people thinking about themselves and their children and their futures and their life questions, but also their loved ones too. I agree. Please.
I'm going to try not to speak too much. One of the other things that I have identified that I heard directly from the community is they want to know what are ways to reduce their risk. How can I live well? Community members, we heard about it in the talks, talking about the facts and all of the dismal numbers that are associated with it, but they're looking for a glimmer of hope as well. And so that comes by way of ways to reduce, healthy living, doing some programming around that. So yeah, I just wanted to add that small piece in.
I like that very much, and I circled the word hope because I think that when you said that, I think that's a wonderful spin on it too. It's not just that they want to reduce risk and live well. We all want to live well so we can look forward to other things, whether it's being for grandchild's birth or just have a better quality of life. So that's why I circled it. I like that a lot. I thought I saw a hand over here. Please.
And this is just going back to research. Again, my name is LaQuetta Allen. I'm from the University of Alabama at Birmingham's Alzheimer's Disease Research Center. And so one of the things that's very important to me is to foster that sense of value in participants by letting them know that they are valuable to us. Especially when you're talking about recruiting them for as a participant for some of these research studies, I'm always telling them that you're helping us to better understand Alzheimer's disease and related dementias, and then going into what that really means. And it really sparks their thinking into thinking, oh, I'm valuable, I'm really helping them, I'm making a difference. So always fostering that sense of value, of how valuable they are as it relates to research, and that they're just not another number, just somebody to come in and do testing and draw blood work and all of that. They're really helping us to better understand the disease and how to treat it and how to come up with the cure.
I think that's really important. And just my shorthand here, sometimes here we just use capital P for participants. So running out of room. So a P is a participant.
Yeah, I like Jennifer Phillips, Night ADRC. I like that you said value, because sometimes I worry when I go out and I'm talking to diverse communities that it feels like I'm commoditizing people. Like if we are saying, well, we are trying to if we're saying we have certain goals, then I feel like it gives the impression we're trying to slot people into places. And so I always feel like I'm trying to find ways to avoid that, and I don't know if it hits or not, but how do we communicate value without seeming like we're filling, so.
I'm going to just see if there's any other questions from any other, Darby, did you have a question? No. Megan's bringing a mic down for you.
Just a quick question. Is citizen, this is really for the group, is citizen scientist an okay phrase? Because I often, for me, it's a way of elevating people because they're participating in the research endeavor. They're so valuable, and I think I heard this earlier, and I really appreciated that. It's so important to elevate the value of their contribution, how near and dear we hold that. It's so important, of course.
I know our community partner really likes that term. We're proud of that.
Did you have another question or comment?
Well, I did have another comment, yeah. This is Darby Morehart. I'm with the Northwestern ADRC. And I just wanted to piggyback on what Josh, you were saying about going out into the community. And I think it's so important that our clinicians are there to answer those healthcare questions. And I don't know, I just want to underscore that it's really important for our community engagement coordinators, managers to, they're the ones, boots on the ground that are really developing those relationships. But, to have our clinical faculty out there at those health fairs means so much, so that the community members can go up and ask them any question they want. It's very valuable. I also see that your box with research is blank. And I was wondering why we're not, what we're not maybe getting in terms of, talking about that.
And we don't, these were just the prompts that we came up with ahead. If we don't get any low grade, if we don't hit all of the boxes.
We don't do that. Because what occurs to me is that we're all coming out, I think, as ADRCs or researchers with an agenda. And that agenda is to recruit people into those research studies. Of course, we're giving back. We are there to give, and we will and do. But at the end of the day, isn't that what we're there to do, is to recruit people into that research study and to diversify those cohorts that so badly need it? So I guess we need to think about that research message. What is it, the message around the research that we're giving? I know the research at Northwestern and what our focus is. And so I think for all of our ADRCs, our challenge is to frame that message in a way that the community can hear.
So, Darby, I think it's nice to be able to have a conversation, and hi, it's great to see you.
Nice.
I think we need to expand that agenda, actually, because I think the agenda is not just getting people into studies. I think the agenda is learning from others, and that means learning from our participants, so that we can be better, and so that we learn some new things that we didn't think about before, so that we can be more impactful, we can be more helpful.
Yes, I agree, and certainly my statement before wouldn't be inclusive of that, of course. So, because we need to, it's a collaborative, it's community engagement, it's working with community to meet those needs. And to, again, they can help us, the community, we can work together on that messaging so that it's not, us needing to do that or define it, but that it's a cooperative and collaborative, and there's a lot of reciprocity there as well.
And I put those two thoughts that we were just describing there, I put them sort of in brackets because we had sort of originally conceptualized this, like just kind of like what are the bigger picture areas that we think or that we've heard that some of other groups with whom we work or with whom we identify want to hear, like things that we already know that we should be doing that we're not perhaps already doing. But I think these are good philosophies, good strategies, and philosophies to follow when we're approaching those questions.
So Lynn again from Yale, and one of the things that I run into when I'm trying to do all of this outreach is we don't have the budgets for it. I mean, when I look at some of these other sites that I've been to, and I see these incredibly large groups that their OREs are incorporated with, I mean, it's Vanessa and I, and we're both a very small percentage of time on the ORE. And it's like, I'm just amazed as to how other sites are able to do the type of recruitment that I hear going on and I saw yesterday in the presentations. So I'm looking for the magic.
Well, I will just say, I know that, and Dr. Silverberg commented, I don't know if she's still listening now, I know that she wanted to make sure, in response to Dr. Croft's comments yesterday, that in the new RFA for the new ADRC grants, we're all required to have two full-time outreach coordinators. So that's going to be a requirement in your renewal. So that's at least, it always takes more. One last thing, and I'll do, but I would say that I think it probably does take more than the NIH. I mean, we know even for our clinical core, forgive me, Nina, if you're listening, even our clinical core, we can't support the effort, and our outreach core is the same thing. We're funding a lot. We do have to use philanthropy to support, to have a larger team. But please, go ahead.
As you can tell, I'm very passionate about this. I want to say that engagement is ongoing. It doesn't stop. Just because the time ends, the ADRC closes at 5 o'clock, it still happens. I can be in the grocery store, I can be at church, I can be at an event that doesn't even pertain to the work that I do. It's 24/7. It doesn't stop. And, when you're talking about making connections for, the community that you're working with, you're on at all times. So, I think one of the misconceptions that exist for some researchers, some clinical staff, is there's a disconnect of understanding relationship and number. And when those two, they don't go together. And I think when there is a better understanding that it's about, building relationship, and oh, by the way, that probably takes at least about 4 touches before you could really break through. I won't say breakthrough, that's not appropriate, but for the relationship to begin to cultivate. It's time. It's time. It's not an easy 1, 2, 3, okay, yeah, that works for the individual who understands research. That's a small subset. When you're talking about the person who is sitting back, who has, valid concerns about participating in research, it takes time. It takes a lot of time, and I think a lot of researchers and individuals in the clinical setting, they don't understand that. And then the other part of that is once you've built that relationship and they get into the clinical setting, with that, not having that understanding can either make or break that touch point into the clinic. So I just want to level set that and put that out there, because I think there's a huge area of opportunity with getting clinical staff on the same page, and not only on the same page, but embracing it. I think embracing it is really important.
I see another hand over here. Would you have something
So
online, Megan?
there were a couple of comments online, and one of them is from Dr. Nina Silverberg. This was from a little bit ago, so I'm backtracking. I apologize for not wanting to interrupt our lovely discussion going on, but she did comment on the use of community scientists rather than citizen, and wondered if we should avoid citizenship questions.
That's a really good point.
I'm crossing it off the board, Nina. I'm writing community.
That's really good. That's really good. Thank you.
And then there's another comment here from Cody Holt, who is one of our coordinators at the Night ADRC, and he says, what questions does the community have about our area of research? Perhaps those should be the questions we're seeking answers for in our research.
Well, that,
Is it Cody? Thank you, Cody, for that, because I think that really is what we need to be addressing as well. I mean, we are coming in with our own agendas. The clinical trials are all set. We're not getting community involvement in the design of those clinical trials. We're bringing them out to the community. We're bringing the R01s to the community. So, exactly, yes, exactly.
I think there needs to be a new set of requirements for protocol development, honestly, and that protocol has the community's voice.
Agree.
You know, because you're right, too often we come in, it's already designed, here's our survey tools, what do you think? You know, we do now run studios, which are extraordinarily helpful, fascinating, and appreciated by those who participate, and they help us a lot in changing our survey instruments, et cetera, but it doesn't change the underlying fundamental nature of what we've been funded to do, and that can sometimes be problematic. I did want to just touch on a comment that you made, because I think there's perhaps a nice way to conceptualize this for the ADRCs. This is a team sport, and I think the most successful ADRCs, I'm guessing, are those that really embrace that and that really do have close collaboration and integration across all the cores, because at some point different participants in those cores interact with the community participants who are sharing their data with us. So I think that does really help. The other comment I want to make is I think, you know, funding will never be enough. There's always more to do, and I certainly appreciate, you know, and thank Dr. Silverberg, you know, for this emphasis on more resources for the ORCORs. I think that's incredibly important. But I also think we have to get a little bit more creative about how we engage other individuals to do some of the work that we need to do around the arena of community engagement. And where we have had some success is in our affiliated studies. And people come to us all the time with wanting the resources of the ADRC, but we've got to take something back. And part of taking something back is making sure that we now meet with people before they submit their grants. We will not talk to them if they've already submitted. We try not to, and really get that message out so that we can make sure that they build in their, you know, resources for recruitment. But then we're also thinking about, because they want to use the ADRC expertise, how do we then make sure that helps us in this larger mission with things like community engagement, providing resources to the community, being present, having sustainability plans, which is something I think we heard earlier. We spend so much, I'm talking about myself now, so much focus and effort on recruitment, but I think what falls to the side a bit is sustainability. How are we going to remain present? How are we going to deliver on all our promises?
Yep. Well, yeah, I mean, I just agree that about retention is what I'm thinking about too, and I think we spoke about this yesterday about the social determinants of health and also the psychosocial issues that really become barriers to participating in longitudinal research over time, and how do we as a center work with our participants to help them remain in those studies when it can become a big hardship to do that over the long haul.
There's a question online from Dr. Silverberg. She's posing this question to the group and states, how can we integrate more now with ACTC and ADNI? They are both doing much more intentional outreach to diverse communities and would be great if we can intersect, utilize our registries to support continued interaction for those that may not qualify for a particular ACTC study or ADNI at that time. Warm handoffs or other ideas.
So maybe we're coming to the end of the time. I don't know if in the last couple minutes here, before everyone else starts flooding back in here, does anyone have any thoughts to address what Dr. Silverberg was saying about ACTC and ADNI, whether we can build on their resources or do a warm handoff to our ADRCs if people aren't eligible for some of those studies?
I know that here at the Night ADRC we have had a couple instances, not specifically with ADNI, but with our leads group where we had participants who didn't meet qualifications or they were closing down recruitment and we didn't have time, and so we were able to do that warm handoff. Part of that's easily facilitated by the fact that we're already doing dual enrollment with those participants. But that has helped to continue to have those people engaged in research and not turning them away.
And I think one other piece that we've tried to work in also too is that, we know some of the things involved in these studies ask for a lot, and we're trying to build some other cohorts that might have other options that, well, you don't want to do 3 PET scans and a lumbar puncture, but maybe we can engage you in another way that kind of is same sorts of ideas of the warm handoff, to not turn someone away who wants to contribute. All right, well, thanks everyone. Other folks are going to start coming back. If you have any last thoughts to come bring up here in a second, but I appreciate your help. And again, thanks for coming and being in St. Louis, and we appreciate everyone thinking about these important topics.